Welcome to the SNF Spotlight Series, your one-stop shop to find out what's really going on in SNFs nationwide. I'm your host, Yitz Rubin, and this is sponsored by Renewal Rehab, the best therapy provider for SNFs nationwide. I'm here with Micahel Peck, the CEO of Patheous Health.
Thank you. Thank you. That's spot on. Yeah, CEO of Patheous Health, CEO, co-founder.
Co-founder of Patheous Health and CEO. It was formed in late 2019 to be a leader in feeding and swallowing health.
That's right.
So, Micahel, tell me how you became interested in dysphagia and how you define it for our audience.
Absolutely. Yeah, so we founded Patheous Health to, as you said, to be a leader in this space. And it touches on some experience I had prior, and we can talk about that in a little bit. But the issue of dysphagia is a pretty significant condition for a lot of people. Could be kids, could be adults, and certainly in the senior care market. In 2019, there were actually 16.6 million diagnoses of dysphagia, leading to significant healthcare costs.
Can you, before you go into the details, can you define dysphagia for someone who's totally unaware?
Absolutely. So dysphagia itself is a impaired swallowing condition. So that means an inability to swallow or an impairment to swallow. Some people can't swallow at all. And as you would think, that swallowing is a big deal when you want to eat or drink and certainly stay nourished. And in its own right, dysphagia is not necessarily a disease, a defined disease, but it accompanies a lot of other conditions. As I said, 16.6 million diagnoses of dysphagia that leads to malnutrition, dehydration, aspiration pneumonia, which you could imagine leads to a lot of healthcare costs. In fact, that aspiration pneumonia issue is a big deal, and there's an expert in the field, Dr. Michael Curry. He calls it the death spiral.
Wow! So this is something that basically someone can't swallow, and
Right.
because of that, there are other forms that come, other sicknesses and diseases that come from not being able to eat, malnutrition.
Absolutely. That death spiral is a big deal, and so in that it could start with dysphagia can come from stroke. Head and neck cancers, you could imagine, kids, cerebral palsy, in the elderly, falls, actually, believe it or not, are a leading cause of dysphagia because people are suddenly bedridden and then they just stop eating, or their neurological issues that come along with that. So dysphagia is a broad category, but very specifically caused by certain things in terms of physical issues and neurological issues.
So if seniors discover that they have dysphagia, can they get better, or do they have to resort to a feeding tube?
The answer is both. Again, dysphagia is not necessarily the disease. The disease a condition that causes dysphagia can lead to feeding tubes, unfortunately, but in many cases it is a treatable condition. There are a wide variety of biofeedback devices, behavioral therapies, other e-stim tools that help that dysphagia condition. We're certainly, with our company, Patheous Health and MBS Envision, what we try and do is get in early, diagnose that condition as soon as we can, and then that helps the whole treatment program. And we're working on other solutions that will enable that treatment path. And in a lot of cases, we believe it is something that can be certainly improved, extends life, extends quality of life, and even potentially getting earlier exercises around dysphagia or swallowing conditions that improve that condition later in life.
So dysphagia is basically, is there a muscle that creates swallowing, and you guys are creating a therapy that deals with that?
Ultimately, the goal is to certainly have solutions for therapy. We're not necessarily developing a new therapy. The good news is in this space, there are a lot of really good evidence-based solutions that are out there. Again, behavioral therapies or programs, if you will. There are existing biofeedback devices. I could name off 6 or 8 different biofeedback devices that have a lot of really good research. Opinions vary on which one of those 6 or 8 solutions that are out there have the right efficacy. It's not really a one-size-fits-all type of solution. Our goal is to bring about a continuum of care, if you will. We call it care as a service. And so we are absolutely working on new solutions that help diagnose dysphagia earlier, get in front of that, what we call the instrumental diagnostic, which is what we do today. We want to get in front of that, diagnose patients that are in senior care or other adults that might be at risk, and then fill out the rest of the therapeutic regimen, even in the area of meal kits and diets. That nutrition management is a really important issue in the care and treatment of dysphagia.
So you guys are you guys have a diagnostic tool to diagnose dysphagia
Right.
Early, and
That's right.
then a treatable plan to prevent it or at least prolong.
Yes, absolutely. So what we do today is focus on that diagnostic part of it. It's called an instrumental diagnostic, and there are really 2 standards of care in the area of instrumental diagnostics. One is it's called video fluoroscopy. Think of it as a video X-ray, right? If you've ever seen a moving skeleton, somebody swallowing something, you can put a little bit of barium in a thin liquid or a thick liquid or even a little piece of food, and you can literally watch somebody swallow through their mouth. You can see them chew, swallow, can go all the way down to their gut. So we can see that, and that's a service we provide today.
So which patients are you typically going to look at? Are you going to look at any patient that comes into a nursing home, or is there like a specific criteria that they need to fall out in?
Yeah, there's. We will be called into a nursing center, a skilled nursing facility, inpatient rehab, home health situation. So we will be called in, and we'll certainly diagnose the patient that is in need. They don't necessarily fit any one particular profile, but again, the reason for dysphagia are many. It could be stroke, cancer, falls, frailty, all kinds of different conditions. So there's no typical patient, no specific type of patient that you say, oh, that patient has dysphagia. I can tell. There's going to be a variety of issues that come about and why we get called in.
So is dysphagia preventable if detected early enough?
Dysphagia, again, is because it's not a disease, it may not be completely preventable, but we believe that the earlier you can catch it, the better you can treat it, just like almost any healthcare issue. And certainly, certain exercises, certain programs, one in particular is called the Micahel Dysphagia Therapy Program. There are things you can do to help treat that. We absolutely believe that this is an area in healthcare that's been ignored, extremely fragmented, and so yes, we think there's an opportunity to really get in front of that issue. Again, you'll never prevent everything, but we think there's an opportunity to absolutely innovate in that area.
Right, so which is going to potentially save a ton of lives.
Save a lot of lives, reduce a lot of costs. When you look at the patient population in senior care, and you know these numbers, it's absolutely staggering. I think the census estimates that there's going to be 72 million people over age 65 by 2030. Unfortunately, I'm part of that. That's going to be, my friends, we're all going to be in that group. And on a global basis by 2050, which is still a long ways out, but still, relatively not too far, it's estimated there's going to be 2 billion people worldwide over age 65. It's one of the largest demographic shifts our country and this planet have ever seen. And if you look at it's all because of that post-World War II birth rate, right? You saw it spike and climb up all the way to about 1966, maybe 1965, 1966, before it started to plateau off. Well, guess what? We're all older.
So how did you go from venture capital and engineering background to senior care?
Absolutely. It was all a well thought out plan. No. I've always been enamored with building something. From childhood days, I just always like to put stuff together. So I was fortunate. Was able to attend a really good engineering program at the University of Kansas, but also realized that I wanted to do more with that. And so I'm proud to be sitting here in Chicago and near my alma mater at Northwestern University, in the Kellogg School, where I got an outstanding business degree. From there, that took me into consulting and venture capital, and that really was the path that got me into where I am now. I was involved in a medical technology company that helped preterm infants develop feeding skills. Left that company and started Patheous Health in 2019.
So are there exercises that people can do to prevent dysphagia?
Yeah, that's a great question. That's not something that's well recognized. So you're not gonna see your fitness app telling you to practice on your throat muscles or swallowing issues. I think that's a big opportunity of innovation, quite honestly. You look at the back end. Once again, I referenced a certain protocol earlier called the McNeil Dysphagia Therapy Program. That is absolutely throat exercises and managing that condition of swallowing. There are tools out there that also help you do that as well, biofeedback devices or eSTEM devices. But imagine if we start to move swallowing and feeding health to the forefront and say, just like you're supposed to do, 30 minutes of cardio a day or 10 minutes, whatever the number is, right? Imagine if you should do some swallow exercises once you hit age 65, so that later in life, when you turn 85 or 90, you're able to improve, prevent some of these things that are going on today.
So can you tell me the difference between the babies and seniors having trouble swallowing, like what the difference would be?
Yeah, absolutely. So that's another really fascinating area. And again, in a prior life, as I'll say, I worked in led a medical technology company and focused on the issue of neonatal feeding. And I was very fortunate to be coached, maybe mentored by a leader in that area, individual named is Sue Ludwig. She leads the neonatal, basically National Association of Neonatal Therapy. Taught me everything I know about it. But infants, and it's pretty simple when you really think about it. Infants are all about development. And that's really where you will see these issues of infant feeding problems. That's the biggest issue, is really that development issue versus more of an impairment, health condition for the rest of us.
So now you're focusing specifically on the impairment issue, not on the development issue.
That's right. Yeah, really, adults are not going to have they aren't going to have a development issue. It's going to be caused, 99% of the time, it's going to be caused by some sort of underlying health condition. Like I said, stroke, cancer, etc.
Right. Meaning for babies, it's the doctors would already know and diagnose if there's a swallowing issue. But for adults, it's like when that may come, when the body deteriorates. And,
that's right.
And gets weaker, so certain muscles would get weaker.
That's right.
So that's
exactly.
Can you tell me about the state of senior care and the shift, how there's been a shift going to home health care?
Yeah, absolutely. It really is a complete step function, in our opinion, from particularly in the skilled nursing market. But right now, you're seeing all kinds of headlines where a lot of nursing homes have been impacted. It's absolutely just been tragic. So you don't want to put people in close quarters, and certainly a patient that is particularly at risk for this particular virus. So you're seeing a big shift to what's called home health. Basically, people are just keeping mom or dad at home. I think I saw a number, it's estimated that 16% of U.S. adults over age 50 are taking care of mom or dad or both. They're basically keeping them at home. Certainly, this business has certainly forced me to think about, where am I going to be in, not too many years out. I would prefer to stay at home. I want to be comfortable in the home that I've built and, conditioned to the way I like it. The good news is you're seeing a big shift there. The healthcare, the payers out there understand that, and they're willing to, they would rather put a few things in your home, spend $500 or $1,000 to put something in your home to make it easier for you to get around and well cared for, versus sending you off to a facility. And so we're seeing that shift now. As a business, we've been forced to react to it, and I think it's here to stay. It's not going to go backwards. That said, these nursing care facilities are outstanding at what they do, and there certainly is a need. But you're seeing the pretty significant shift to home health.
That probably makes it a big challenge. It's less consolidated, your patients, and you now have to.
Absolutely.
It could be a lot more costly also.
That's right.
From place to place.
Absolutely. It's going to force a lot of innovation, and it does impact cost depending on how you go about it. Certainly, we're, from a cost perspective, we would rather go into a single location and diagnose, 4 or 5 patients versus having those 4 or 5 spread around, Chicagoland as an example. So yeah, that does impact cost, but it also is going to force. I think it's going to force a lot of innovation. I think you're going to see a massive shift, a massive recognition. You're already seeing some of it now, but you're going to see a massive recognition of that opportunity in senior care.
What would you say would be the difference between like a hospital and a SNF experience in regards to diagnosing dysphagia?
Certainly. So one of the unique things we do is we're able to bring our system, our diagnostic, on site to a skilled nursing facility, or for that matter, home health or assisted living. So that makes us very unique, and we can literally bring our system inside a facility. We can do our diagnostic not at the bed, but certainly in some cases at the bedside, or another location inside that facility. So that's very unique. That's an incredible value proposition, certainly in the age of COVID. For those that don't have our service available in their area, or anything similar, they have to send that patient out to a hospital. So today, that's a problem. We know of many instances where if they have to send that patient to a hospital, that patient's coming back and quarantining for 3-4 days or even a week. Really depends on that policy. So, and when you think about that elderly patient, frail, maybe probably has other conditions, just that fact of sending them to a hospital, it's not going to be just a quick trip up the street. Put them in a van. Certainly today, and with a lot of snow outside, that's just not ideal, right? So again, the value prop for us is that we can keep that patient comfortable, better quality of care, a better outcome in terms of that diagnostic. Again, imagine if we have to load you up and take you to a hospital 10 miles away. It's cold, windy outside. By the time you get there, once you do get that diagnostic done, it's not going to be a good quality diagnostic.
So I understand that there are some challenges in regards to the payment model and whether Medicare, Medicaid,
Right.
and the insurances would pay for that. So
Right.
sometimes, even though it might be safer and better for a patient to
Right.
stay in the facility,
That's right.
sometimes it's impossible for them to do that based on the regulations and payment
Right.
models. So how does that work?
Yeah, so as we all know, in skilled nursing facilities, this issue of consolidated billing is a big driver. And the other big issue with that is what we call place of service. We can charge a certain fee for our diagnostic, for our exam, in one location in a skilled nursing facility. If that facility is connected to an assisted living side, we cannot charge the same fee or get the same reimbursement on the assisted living side. So it does. It's a long way of saying it does matter It doesn't mean that that facility is necessarily forced to send that patient to a hospital, but it does impact if they can get a diagnostic at all at some point.
So do you have like a set schedule of, let's say a SNF partners up with you? So how often would you go in? Do you go in like weekly, monthly, or you stay there?
No, it's a good question. We focus more on just the service model. So our goal is to be, we don't have a consistent schedule because the patients aren't consistent. As a skilled nursing facility director of rehab, you have a patient that's in your care today and you think they have a dysphagia condition and you need that diagnosed, we can be there tomorrow. And so that's a very unique proposition versus sometimes, a hospital, if they have to send them to the hospital, that can be 2 or 3 weeks out in terms of getting that patient scheduled. So that impacts a lot of, that impacts that patient, their quality of life, that impacts that treatment program, and they're probably not getting the full care that they need because you just don't know what their exact condition is with that dysphagia issue.
Thank you so much, Mike. It's been a pleasure.
Thank you very much. Appreciate your time.
Thank you for sharing this tremendously important part of senior care. The SNF Spotlight Series highlights healthcare heroes and thought leaders in the skilled nursing community. We're building awareness, trust, and shining the light on SNFs. So stay tuned. Remember to like, comment, and share.